Welcome everybody to the diabetes community of practice. I lose track of the numbers of these that we've now had. I'm guessing this must be the 5th or 6th community of practice. Sarah's nodding. Same format as we've done before. You've got the slides up there. So we've got 2 presentations. The first will be from Umar Chaudhry, who's from City St George's, University of London, on the title there, Risk of Infections in Diabetes, which I believe is using CPRD. And then from University of Bristol, Alain Amstutz is going to talk to us around some OpenSAFELY diabetes research. We will, as before, we will have both sessions back to back, and then we'll take Q&A after. You can see there's lots of QR codes on the screen. Please do scan away now, or presumably we'll put this up again at the end. And we particularly want to hear feedback and a plug that we'll come back to at the end. If you do want to present to this group, just let us know. And I think on that, okay, thank you, Sarah. We are recording. Yes, certainly when we come to the Q&A, if everyone have their cameras on, because it makes it much more friendly. Otherwise, mute, and let's get started. That's more like it. Yeah, we're there.
Brilliant. Thank you very much, Ewan, for the introduction. So good afternoon, everyone. And first of all, thank you very much for inviting us to present the work that was undertaken by the Primary Care Epidemiology Group. So my name is Umar. I'm a GP and currently a doctoral fellow at City St George's. And on behalf of the Primary Care Epidemiology Group, we'd like to present this work looking at the increased risk of infections in people living with diabetes. This work was led by Professor Tess Harris and Professor Julia Critchley and Dr. Ian Carey, who led and completed all the analysis. Professor Tess Harris is amongst the audience that I can see. So this work was funded by the NIHR RFPB stream. And actually, Julia Critchley was invited to provide a commentary and a summary of the work focused on diabetes infection at the recent ADA conference. So it's important to first of all say that this work was completed side by side with our patient study advisory group, who really did help steer this research throughout. And we've put a quote up here which really emphasizes the importance of infections in diabetes, and I'll just leave that up for a moment for you to kindly read. It really sort of highlights the importance of infections within diabetes, and actually the community involvement was really strong, and they really understood sort of the messaging that we were trying to bring across. So we really would like to thank them for their contribution throughout. Now, we know that managing complications of diabetes is an integral component of diabetes care, and complications is where the substantial sort of burdens when it comes to clinical and financial responsibility lie. We're aware of certain diabetes complications that are well known. These are the classical macrovascular complications affecting the eyes, kidneys, feet, nervous system, circulatory systems. These have been studied extensively. And many gains have been made in trying to prevent or delay these complications through screening and prevention exercises. And so as mortality from vascular complications has declined, there are other emerging complications that are increasingly more likely. So you have cancer or neurodegenerative causes, but also you have an emerging complication as diabetes and as infections. Now, infections represent an acute complications compared to some of the other complications that we just talked about. And this is a leading cause of significant burden, both in mortality and in terms of hospitalization. It has gathered particular interest following COVID-19. The relationship between infections and diabetes is an interesting one. So higher sugar levels predisposes you to infections, and infections themselves leads to higher sugar levels. So you have this bi-directional relationships. And previous analyses have shown certain infections that are higher risk in diabetes and certain management options that have been advocated for. If anyone is interested, there's a really good review article that highlights this bi-directional relationship between diabetes and infections by Richard Holt in Diabetology. And compared to people without diabetes, the high risk of infections has been seen in many cohorts. The primary care epidemiology group has previously undertaken work on this, looking at the UK and the English data set focused on diabetes infections, and the higher risk of infections has been replicated in other cohorts around the world. Understanding mechanisms remains quite key, and it's thought that poor glycemic control, both in terms of average and variability, is shown to be an important factor. Despite this, there remain a number of important unanswered questions. The previous work that was undertaken was only focused on adults above the age of 40, and we know that diabetes is affecting more and more adults at younger age groups. What about different races or ethnicities? What about BMI, which is an important effect modifier in diabetes? And how much of this infection is there a burden of mortality? What about pre-diabetes, which is becoming an important consideration as part of a continuum? And what is the precise role of diabetes control when it comes to infection risks? And these were all the sort of questions that we wanted to answer as part of this work. So, as Ewan mentioned, we used CPRD Aurum, which included GPs and approximately 50 million patient records linked to hospital and mortality records. We used an algorithm to identify those with type 1, type 2 pre-diabetes. So these are adults aged between 18 and 90, alive on the 1st of January 2015, and who'd been actively registered for 1 year. These were matched to people on age, sex, and ethnicity. And it's important to say that there was good ethnicity recording within CPRD Aurum. The outcomes that we were recording were of infection within a 5-year data collection period. And so this was either infections in primary care, so GP infections, infections in hospitals or hospital admissions through linkage, and mortality through ONS. So these are the outcome measures that we were looking for. And it was infection rates over a 5-year period during the data collection period. And what we were doing was comparing the infection rates within people with diabetes and those without diabetes to calculate the incidence of infection rate ratios, comparing the two. We wanted to look at a number of confounders and effect modifiers using this large data set to help really understand these risk parameters further. In terms of the results, so this figure compares the rates of infection over 5 years between people with diabetes or pre-diabetes. So the uncolored bars are people without diabetes. The colored bars, so green or blue and orange, representing type 1, type 2, and pre-diabetes. We'll try and be quite consistent with these coloring schemes. And here we can see that for people with type 1, type 2, and pre-diabetes, there's a higher risk of infection compared to people without diabetes. This is for primary care infections. And if we look at hospitalization for infections, we can see that there's a higher risk of infection, both in type 1, type 2, and pre-diabetes. And in fact, actually, for the type 1s, the risk for hospitalization-related infection is higher, is highest amongst the different sort of risk scores. If we were to stratify the type 2 and the pre-diabetes amongst the different ethnic groups, and this is what, if we take the orange and the blue bars and we stratify these by ethnicity, we have the following figures, again, for primary care and hospitalization below. Looking firstly at just the white ethnic group, these tend to be higher compared to the other ethnic groups, and that is often because they are older in age, and age often predisposes one to the higher risk of infection. Older people are at greater risk of infections, and it's the older risk for hospitalizations as well that's equally important. The South Asian group particularly has the higher primary care infection rates than the white ethnic group, despite the age differences that exist between the two. But broadly speaking, if you look at the stratification by the ethnic groups, the infection incident rate ratios across the different ethnic groups are largely quite similar for both primary care and hospitalization-related infections. We now wanted to estimate the population burden of having diabetes towards developing infection in both primary care and hospital. This estimates the attributable risk across the whole adult population and then within each of the ethnic categories. So here we can see that of infections in primary care, it is almost 6% and 10% of in hospitals attributable to either pre-diabetes or type 2 diabetes. However, once we classify this by ethnicity, these were highest amongst the South Asian population, and this is due to the higher prevalence of diabetes within the South Asian population. Obesity is often seen as an important effect modifier, mediating a number of risks in diabetes. People with high BMI levels, regardless of whether they had type 2 diabetes. So this is people without diabetes, increasing BMI on the x-axis, age-stratified incident rate ratios across the y-axis. We can see as the BMI increases, the risk of infection also increases. And this U-shaped curve, so that's also a higher risk amongst the very low BMIs. This U-shaped curve increases with age. If we compare this, so this is people without diabetes. If we have a look at the risk, the association in people with type 2 diabetes, we can see that this U-shaped curve is maintained, but obviously the rate of the risk of infection is higher in type 2 diabetes. We then wanted to try and understand both glycemic control and its effect on infection risk. And here we looked at hospitalization-related infections only in type 1 and type 2. So type 1 diabetes over here, type 2 diabetes on the right. And here we've got increasing average HbA1c level, and then the incident rate ratios for infections. For both type 1 and type 2 diabetes, independent trends of increasing infection risk were seen with higher average baseline HbA1c levels, and also with visit-to-visit variability in HbA1c. These are the baseline HbA1c summaries before any infections were ever accounted for. And this was not explained by adjusting for potential confounders, including adjusting for average or variability and vice versa. And we've got a similar higher risk at low. These are sort of J-shaped curves that are particularly the case for the average HbA1c levels. We then wanted to look at attributable risk fractions. And here we can see that particularly for the type 2, it's the visit-to-visit variability. So the HbA1c variability that poses a higher burden when it comes to infection risk. Focusing now on infection-related mortality, we used a different method to try and understand the burden of mortality caused by infections in people with type 2 diabetes. So looking at infections across all ICD-10 chapters rather than looking at it just at the infections related chapters. So if we take pneumonia, for instance, this is not cited within the ICD-10 chapter for infections. It's actually in a separate section. So we counted infections across all ICD-10 chapters. Here we can see that the uncolored bars are the mortality rate in people without diabetes, and then the colored bars are the additional risk that exists with type 2 diabetes. So for instance, with cardiovascular causes of mortality in type 2 diabetes, there is a doubling of the risk that exists. So if we count infections across all of the ICD-10 chapters, infections were the third highest underlying cause of death among people with type 2 diabetes after a cardiovascular disease and cancer. And this is a much higher contribution than counting only from the specific infection chapters alone. And now we wanted to look at different sort of infection subtypes and which infections were related to mortality within type 2 diabetes. So once again, uncolored bars are people without type 2 diabetes, and the colored bars are the additional risk that exists in type 2 diabetes. And so this summarizes the infection-related mortality rates for different types of infections in people without diabetes and then in people with type 2 diabetes. And the highest hazard ratios that we can see was for bone and joint infections. But if we look at the largest excess differences in mortality rates based on the underlying cause, we can see that this is for pneumonia. Sepsis was handled differently because you can have an underlying cause of death because of sepsis, or it could be mentioned at any point within the death certificate. So this was handled slightly separately within the analysis. So what we can conclude is that across both primary and secondary care, there is a higher risk of infection in type 1, type 2, and pre-diabetes. And what we can see that with the higher infection risk in pre-diabetes, this suggests that this is in a continuum and doesn't actually start at the time of the diagnosis of diabetes. When we stratify this by ethnicity, we can see that the rates are generally quite similar across the ethnic groups, but the population risk is substantially higher within the South Asian population, likely related to the higher prevalence within the South Asian population group. We looked at different effect modifiers, and here we can see that obesity, the impact of obesity on infection risk is independent of type 2 diabetes status. We looked at glycemic control, and you can see that both average and variability in blood sugar levels both affected infection risk. In type 1, higher average level was important, whereas for type 2, variability was more important. And when we look at causes of mortality from infections, we can see that infections was the third highest underlying cause of death in type 2 diabetes, only exceeded by cardiovascular or cancer-related causes. There are a number of strengths to this research. We had an extremely large sample size, approximately 800,000 participants within the population. This allowed us to have good representation of different ethnic groups with high ethnicity recording. It allowed us to therefore be representative of people living with diabetes in England. And the linkages through hospital records, as well as the primary care data set, allowed us to ensure that that we were able to replicate we were able to find the same sort of finding of increased infection risk in multiple data sets, so reducing the limit of potential bias. There are, of course, a number of limitations. For primary care infections, this is largely clinical based without sort of laboratory confirmation, unlike in hospitals. Pre-diabetes is often now screened for in people above the age of 40, but it's likely to be underascertained. There are probably quite a lot of people in the population who have not yet been diagnosed with pre-diabetes. And it's also important to remember that one might be undertaking a number of sort of blood tests at the sign of acute illnesses. So around time of infections, you may more likely to have different types of blood tests, including HbA1c. And if we go back to that bi-directional relationship, that's important to then consider. So hopefully we've tried to establish is that there is a higher risk of infections in people with type 2 diabetes. What's really stark is that there perhaps should be greater emphasis of this in different guidelines across the world, in UK, European, US guidelines, which is less apparent at this moment in time. And this is really important for people with diabetes, clinicians, policymakers. The higher risk of infections could allow people with diabetes think about sort of prompter presentation and quicker management of infections, and this will potentially lead to reduced infections that are necessitating people to be admitted for hospital. The landscape of diabetes care is obviously changing, with capillary glucose monitoring systems being increasingly used. It provides another opportunity to think about sort of glycemic control and risk of different complications, including infections. Alongside sort of newer guidances that has been issued, particularly the use of SGLT2s as first-line anti-diabetes medications and GLP receptor agonists as for weight loss medications, it remains to be seen in terms of the impact of this on infection risk in the future. It's really important to say that there is a high and rising prevalence of both pre-diabetes and type 2 diabetes and obesity. All of this has substantial health burdens, particularly when it comes to diabetes care management, particularly of complications. So it's important to bear all of this in mind. So my references, I'd like to very much acknowledge everyone as part of the primary care epidemiology group, as well as the wider collaborative and study team. It's outlined below. We would very much like to acknowledge the Patient Study Advisory Group who helped steer us throughout this journey, as well as the NIHR, the RFPB grant stream to help fund this research. I've just put a few of the QR codes for all of the relevant papers that have been published as part of this work, which perhaps go into a little bit more detail. But thank you very much. I'll hand it back over to you, Ewan.
Well, thank you very much for having me. And yes, this has a slightly different spin. I think this presentation, I will not present a lot of results, but rather, OpenSAFELY and how to work with it, and then a few ideas. Thanks a lot. I'm a postdoc research associate partly in Basel, Switzerland, where I do more trial methodology, and then partly in Bristol with Jonathan Stern, Rachel Denholm, Venetia Walker in the electronic health records group, where we work with different secure data environments, but one of them pretty much from the start is OpenSAFELY. So I will take you a little bit through OpenSAFELY. I heard there's a lot of interest in this platform and show you 2-3 ideas. Now, what's important to note up first is it was built up during the COVID-19 pandemic, this platform. That it was very much focused on and restricted to COVID-19 research at first. It was built up by the Bennett Institute in Oxford, Ben Goldecker and his team. And the way it works and the way people interact with through this platform with NHS electronic health records is quite different to many other secure data environment, or also to CPRD, as we just heard before from Umar. So there are 3 key bits with OpenSAFELY. One is it interacts directly with the GP data center. So it's installed in the GP data centers, and fortunately, in England, there are only 2 data providers, software providers. That's TPP with the servers in Leeds and has a bit more GP spread all over England that use it, but a bit less patients. And then EMIS with the servers in London and mostly services the GPs in and around London. And the platform directly interacts with TPP and EMIS. I'll show you in a minute how. Second key bit is that all code, so be it from the platform itself or by any user on any project, is shared publicly via GitHub. And the third important point is that it heavily relies on dummy data, because the whole idea behind OpenSAFELY is that you never see one person per row data, even anonymized. So it's not like CPRD, you get the data set, the CSV file, you never see individual level data. You work on dummy data, you sync it through your GitHub to the OpenSAFELY GitHub repository, then it takes it into the secured vault, so be it TPP in Leeds, so it either sends it to Leeds or it sends it to London, to EMIS, takes your code into the secured vault, executes your code, and takes out the aggregate results, and then you can log in basically to the TPP or EMIS server through a VPN and see the aggregate results. It gets output checked by output checkers so that you don't release any disclosive information. And then once that's done, you can basically access the results and use them for your publication. I know people here, I think on the call, are quite interested a bit how to interact with this platform, which is a bit new for people. So I thought I'd bring a few more detailed level workflow insights. One key bit is, as you all know better than me, that you cannot just request the whole EHR, right? You have to first define a study population. The same thing in CPRD, right? You first say, what is your study population you want? In CPRD, it's someone else who does it for you. Here, you have to define first your study population yourself. And this you run through or use for that a coding language that the Bennett Institute developed specifically for this purpose, called ERCL, Electronic Health Records Query Language. Why did they do this? Because EMIS and TPP have slightly different data infrastructure, so you would need to write 2 sets of code, right, to get your study population. ERCL does that for you. You write 1 set of codes, and behind, once you execute it, it translates the language directly to EMIS and TPP server structures or data infrastructure structure. And you can see it's heavily based on Python. It's quite straightforward to use. So here, for example, you create your data set, you define a population, say everyone with a date of birth before December 99. Then I have here, for example, 2 asthma codes, DMD medication codes. Then you say, okay, I want to know from the entire study population if they have one of these codes, sort them, and for every patient, I want the last entry. And as a column, I then want for each entry so the date of this DMD code and the code itself. So which one of the 2 is used for each person. So it's quite a readable, friendly to use coding language, even for myself as a clinician, something that you can really learn quite fast. That's the very first step. Once you have that, you generate dummy data. So you basically run this data set definition. You see it here in the middle. I run it locally on my laptop. You can also run it in a code space on GitHub, but locally sometimes it's even easier. And then you get your output dataset.arrow, so kind of a CSV file, which you then can open and look at it as if it's a real CSV file. You see below a bit how this is generated. I now said, please generate 100 matching patients, but you can increase that to 10,000. It builds the data set, and then you have it basically on your local computer, and then you can start writing your analysis code in any language you want. So then you can use data coding or R or Python then to make an analysis based on this data set. So it's just this first initial step, which you have to use this new Urkel language. Then you run, as mentioned already, everything through GitHub, link it to the OpenSAFELY GitHub space or repository. It does a few automatic checks if it will run in the real data. And once everyone is happy, you can send it off to the secured servers. You decide TPP or EMIS, and then you get your results back. So this is a very brief overview, but happy to go more into detail. I think what's interesting with it is that different to some secure data environment, specifically also CPRD, this is quite real time. So there's no data management, that half a year it takes since the last export. Basically, when a GP types in new information, you have it. Of course, some have a week lag in terms of export, but usually you have it. And that's why OpenSAFELY, they could create these really very nice and informative real-time data during the pandemic, looking who gets the vaccine, who doesn't get the vaccine, split by here it's deprivation. And really inform NHS England who has not received the vaccine yet and who has. It's very transparent because everything is going through GitHub. Every action is logged. So you see here on top, for example, this is my project here, implications of metformin, long COVID, my workspace. You can click on it, you can say view, and then you can see which analysis I run. So you can see all my p-hacking I'm doing. So it is a very open and transparent process, which also increases reproducibility, right? You can really run the same code, again, which you have used for your publication. Others are also encouraged to use your code, to share code. There's a lot of collaboration going on because you see all the others coding, right? Anyway, so it's all public. It's not everyone on their own laptop. And of course, privacy is very high because you never have access to this individual level person data, which increases trust. And that's also why OpenSAFELY has received a lot of attention, even from patient advocacy groups, such as Med Confidential. They're very critical working with NHS data, but they have praised this kind of system of workflow and working in the NHS as one of the most trustworthy. And as mentioned, the collaborative aspect is quite high. Usually our projects are across different universities, different people working on it. It's really not this kind of everyone with their CSV file alone on their computer. And it really encourages it because it's so open, it's so collaborative. OpenSAFELY also has a few interesting tools embedded. So one very obvious tool is what I mentioned already. You write one user code and then you execute it on two servers, and then you use meta-analytic tools to kind of combine the results. That's already embedded. But the other tool, which I will go a little bit more into detail because it's related to diabetes research, is a tool called reusable action. So we know that many users in OpenSAFELY will need the same research steps, like the same functions, they need to define the same thing. And actually the platform wants to encourage people to share knowledge and to share these tools. And a very specific one is through a reusable action. It's kind of a repository of existing functions, which you can access very easily. I'll show you an example. I think this I skip a little bit, not so interesting, but of course, OpenSAFELY has produced a lot of output, especially around COVID-19 vaccine effectiveness, safety research, around the COVID-19 drug repurposing research, hydroxychloroquine, here the maps, a lot of health system research. This one, a very nice one where they showed how, GPs maintained the important services, be it, INR testing, blood coagulation tests, but dropped serum cholesterol testing during the pandemic, or during the lockdown, which is arguably not the most important one, not the most critical ones. It's a very nice platform to also do health systems research. And there was one trial so far, a cluster randomized trial, which as a trialist by heart, of course, that's amazing. If you can see, you can do a cluster randomized trial with over 6,500 clusters. Any cluster trialist will be very, very happy. And exactly as already mentioned at the beginning, since end of February, officially, the platform is open for non-COVID research. There's an application process. NHS England reviews it. There's PPI involved, and now there's also a fee involved. So at the moment, you pay 25,000 per project. Before, everything was for free. What's in it? Very, very briefly, basically the full GP record, every prescription, diagnosis, lab test results, referral, vaccination, linked to the death registry, so including the death certificate, causes of death. It has a few particular data sets linked in it that had to do with COVID-19, so COVID surveys, COVID-19 therapeutics, high-cost drug data set, and then the renal registry. This will change a little bit now in the non-COVID era, but they try to also now link further data sets in future. And then it's linked to the HES, so to the hospital episode data. So there's not detailed hospital data, but at least, admissions, diagnosis, more or less what happened at the hospital, when did people get discharged and admitted. I'm currently finishing a project on the protective effect of metformin among outpatients on COVID-19 outcomes, severe and long COVID outcomes. I can't share results yet. They're still under review, but I think it's also not the main topic or focus of this presentation. It's really more about OpenSAFELY, but I can explain a little bit more. What's maybe more interesting is that as part of this project, I also had to, of course, define diabetes in the EHR, because I wanted to study starting metformin versus not starting metformin and looking at COVID outcomes. And for that, I needed a population that is more or less similar, so that it do not have positivity violation. So I chose the diabetes population and look at who starts metformin, who doesn't start metformin. So diabetes was a very important variable in my study. And of course, it's not so easy to define who has diabetes and who has not diabetes. And you have done a lot of research on this topic, I'm aware. So you know this much better. The reality is, it's a mess. There are diagnostic codes, there are process codes, there are lab codes, there are medication codes. And in the end, many people have conflicting codes. And somehow you need to tease out what is now this person's diabetes status, type 1, type 2, unlikely, other, and so forth. And we have implemented one algorithm in OpenSAFELY. We call it the Sophie Eastwood algorithm. And I am very happy to see Sophie on the call today, so she can talk about the algorithm in much more detail. That's fantastic. This is how it looks like, more or less. It has been a bit adjusted. That's the one I'm currently using. And because we knew many people will want to use such an algorithm in OpenSAFELY, because many work with diabetes as a variable, be it for eligibility, as a covariate, as an outcome, we implemented this as a reusable action. So I did a lot of work around how to take now this algorithm and make one nice function around it, but then package it so that everyone can access it. And now it's available publicly under this homepage as a reusable action for all users in OpenSAFELY. It accepts 21 input variables based on primary, secondary diabetes-related codes. It checks the input, all the variable formatting, and then it runs the algorithm, and it gives you basically back two variables, what is the type of this person, what's the diabetes type, and what's the diagnosis date. And then you can also choose to keep some helper functions or helper variables or not. And that's how it looks like. So everyone working in OpenSAFELY runs all actions through this project YAML file. And there you can now just say, okay, I just copy paste this block. I add all my variables, how I name them in my data set. So this set does not have to be exactly the same names. I map them to the correct variables that the function basically needs. And then I run it and I get back the result. So that's a reusable action. Now, because we know there is actually the other algorithms around, and likely also a little bit better ones, we are very fortunate to have a brilliant intern, Halimat, who is from the HDR UK Black Internship Program and is now doing her 2 months internship implementing this algorithm that you have developed now for OpenSAFELY, so that basically we have one additional variable here in the reusable action where users can choose, right? I mean, in the end, it's nice if people can say, okay, maybe for my purpose, the previous one based on UK Biobank is more accurate, it's better, and so that you can choose which algorithm to run in OpenSAFELY. That is the idea, and I think with this, I'm already at the end. Thank you very much for having me, and very happy to answer questions.